interest in this topic. What is intumescent cataract? Since 1996, Brown and Brown defined intumescent cataract as a swelling of the lens because of fluid influx due to epithelium impairment. And it is challenging to operate because of positive pressure within the lens and the absence of retroilluminance. There are several different types of intumescent cataract were defined. Several researchers demonstrated intumescent white cataract is a series of pathological change and the dysfunction resulting inward osmotic pressure and lens epithelium cell swelling. As we know, capsule problem is the most dangerous in these cases. High surgical complication rate of around 10% have been reported, including capsule tear, drugged nucleus, PC rupture, vitreous loss, and conversion to ECCE. But what happened to intumescent cataract capsule? Central capsule thickness problem or lens epithelium cell dysfunction? In this research, we can see no significant difference in central capsule thickness in intumescent versus nuclear cataract, 18.5 versus 18.5 micrometer. Ultrastructure of anterior lens epithelium in ordinary nuclear cataract by electron microscope showed no swelling, no rounded extrusion, and no degeneration of the epithelium. However, the morphological feature of intumescent cataract shows extrusion at the basement membrane epithelium border embedding cellular material filament in the basement membrane. This pathological change results in represent weak point for capsular stretching, tearing, pressure, and longitudinal integrity, and finally lead to capsular tear. Therefore, the capsular fracture not only results in tear to the periphery during capsulosis, but also results in higher rate of capsular break during every step of the surgery. This is why I spent some slides to talk about the pathology of intumescent cataract. Okay, let's back to the surgical video. The first key point in performing intumescent cataract surgery is OVD injection. Because of fragile anterior capsule and high lenticular pressure in such cases, we must inject the OVD to fulfill the anterior chamber to prevent the anterior chamber tear like this. Capsulosis is definitely one of the most important procedures in these cases. In order to make a larger than 5 mm diameter capsulosis through a lesser than 3 mm clear cornea incision, I always emphasize pivot concept, especially in these complicated cases. Due to absence of relief in such cases, after puncture the anterior capsule, I make a larger flap to release high lenticular pressure. And each time the flap is released, it should be elevated and make a fold. This makes it easier to re-grab the flap following. By using flags, we can see we perform capsulosis easier, quicker, and safer than manual capsulosis. But we need to carefully to check if the capsulosis is complete. The next step is hydrodissection and lens rotation. I separate the hydrodissection into 4 detailed steps, including BSS injection, spread, stop, and decompress. First, inject teeny quantities of BSS. Then, let the BSS freeway spread across the posterior capsule area and stop right on the opposite equator. Because absence of ray reflex, it's more difficult to perform hydrodissection in such cases than ordinary cases. Inject too much of BSS will cause flowing back into the thinnest posterior pole area. I consider the major reason why the PC rupture is occurring in this procedure. Then, I consider the most important step in hydrodissection is decompress the BSS behind the equator. Because absence of ray reflex, we must pay more attention in such cases when performing hydrodissection. Just inject teeny quantity of effective BSS, and the most important step, decompress the BSS behind the equator. Even if we use flags in such cases with absence of ray reflex and obscured by air bubbles, we should work slowly but accurately in each step that I just mentioned. After successful hydrodissection and lens rotation, the next step is chop and split the nucleus. By traditional technique, we can see it's very difficult to do phaco chop for a full thickness segmentation of a very hard mature nucleus like this. There are always a posteriorly very strength kept nuclear fragments attached to each other. That will definitely endanger the following procedure. Within the flags, the similar rock hard nucleus can be full thickness slit in half along the laser cut plane. This makes the following procedure easier and safer. About the CDE, we can see from this video by using traditional phaco emulsification. In this intumescent case, after complete phaco emulsification, the CDE was 41.66. Let's see a similar intumescent case. After femtolaser performed the CCC and pre-chop the lenses, I can easily remove the fragmented nucleus despite the shallow anterior chamber and central corneal opacity. The CDE was only 14.11 and the UCVA at the first post-op day is 0.9. This table is my personal consideration about the difficulty between flags and phaco emulsification in all steps by 3 groups: flags, phaco emulsification by experienced surgeon, and by young surgeon. 5 score is great challenges. 0 score is much easier. We can see difficulties in managing intumescent cataract between flags and traditional phaco emulsification by experienced surgeon is similar. However, it's much more difficult in young surgeon by traditional phaco emulsification. My conclusion, I consider flags provide safer procedure, faster recovery, and better outcomes in intumescent cataract surgery. However, surgeons' experience and the cost of the flags are another issue. Additionally, I would like to share my personal tips in any kind of complicated cataract surgery. And thank you for your attention.